Good morning, everyone. To continue with the theme of aged care, I'm Brendan Fu. I'm one of the advanced trainees in aged care, and I'll be presenting on behalf of Michelle Lai, the Medical Education Unit, of one of the projects they've embarked on in the first 6 months of this year. So just a bit of background on delirium, apart from my special interest in this area and why we chose to do it. It is defined for non-clinical people in the room. It is defined as an acute confusional state. It is a very common clinical condition where it occurs to up to 55% of patients with hip fractures and up to 20% of all patients who are admitted to hospital. It's often misdiagnosed, not detected, and or not identified in hospital. And guidelines and studies have clearly shown that management of delirium is vital in improving patient outcomes, and we thought that this is a good clinical area and education and training area to target. Just a brief introduction about education and training in delirium. So guidelines and clinical care standards in North America, European and Australian Society of Psychiatry and Geriatric Medicine do recommend the use of a trained and competent multidisciplinary team. And the use of interprofessional learning models and simulation-based training has been studied quite extensively in the undergraduate setting, particularly in the medical and nursing student cohort. And one study that has been quoted is the one that was done in Monash, where they have interprofessional learning in using simulation in medical and nursing students in the undergraduate cohort. What is lacking, I suppose, is the studies on medical and non-medical health professionals in the workforce itself, rather than the student cohort. So we decided that this was a good opportunity for us to develop and implement a collaborative training effort, at the same time performing some studies and research on the efforts they were putting in. So the aim of the study was to evaluate the effects of interprofessional learning using simulation on participants' knowledge on delirium. We also want to evaluate the effects of simulation-based IPL activity on participants' readiness for interprofessional learning. And lastly, we also took the opportunity to examine participants' experience and reaction to the delivery and content of a interprofessional simulation-based workshop. And we hypothesized that using a simulation-based model and interprofessional learning that improves the knowledge of the participants on delirium care and the readiness for interprofessional practice. And we also hypothesized that interprofessional learning uses simulation enhances the learning experience of the participants as well. So in our study, the eligible participants are all junior medical officers, nursing and allied health staff employed within the South Metropolitan Health Service. The outcome measures that we looked at is a knowledge-based test, and I'll go through in a bit detail in terms of what that consists of. We also use the Readiness for Interprofessional Learning scale as a measure of the readiness for interprofessional learning. And then within that survey, we incorporated a question where we ask an overall rating scale in terms of how participants rate the importance of interprofessional learning in promoting interprofessional practice in the workplace. And we also allowed some areas for questionnaires and free text box for evaluation of the program as well. The statistical support was provided by Dr. Michael Black from Murdoch University, and in short, we effectively performed a non-parametric Wilcoxon pair T test for the pre and post results prior to and before after the intervention. And this research was granted low-risk ethics approval by the South Metropolitan Research Panel. A bit more detail in the tools that we use. So the knowledge-based test is a 12-question knowledge-based test that is derived from published nursing and medical literature on clinical care on delirium. And the Readiness for Interprofessional Learning scale is a 19-question questionnaire that covers 3 domains, which predominantly teamwork and collaboration, professional identity, and roles and responsibility. Bearing in mind that it's a modified version, but there was specific reason why we didn't choose that, purely because from a time frame point of view and also from a practicality point of view as well. In terms of the workshop, how do we design it? So we started with we actually had a learning needs assessment of junior staff within the South Metropolitan Health Service as well. And from that, we actually derived a curriculum for the program as identified from the learning needs assessment. And then we also created an educational video that's 20 minutes long that incorporates multidisciplinary input and information and briefing as well. And then we subject the participants to 2 simulation-based scenarios, including briefing and post-simulation debriefing. And what happens is all participants have a pre-workshop evaluation of the knowledge-based test and the RIPLS, including the questionnaires, and then they have an evaluation after that. And as you can see, that's just an example of the resources that we produce, which came from the other clinical training resource development grant as well. So just to go through the results now. So over the period of 6 weeks, we conducted 14 workshops, and we had 98 people going through their workshops, medical, nursing, and allied health. And that just gives you a brief idea. So there's 98, doesn't come out that well, but 98 volunteers registered for the program. 97 participants consented to participate in the research component. 1 was excluded, and no clear reason was recorded. Then we divided them to 2 arms. So there's an interprofessional arm where medical staff go through the program in the interprofessional arm where they have 30 medical staff, 31 nurses, and 9 allied health throughout the program. And then we have the uniprofessional arm where it's just doctors going through the program. And then participants on both arms complete both of the research, the test tools. And these are just a number of incomplete data that we could not get from knowledge-based tests. So small numbers in the RPL arm and fairly small numbers in the UPL arm, purely from a knowledge-based test point of view. Unfortunately, we do have quite a lot of non-complete data in the RIPLS, which will reflect on the results in a bit later on. So just a brief, this is just a baseline characteristics of all the participants. So medical staff consists of about 60% of all the participants. Nursing, we had 31 nursing staff coming through. And in terms of allied health, although the numbers are small, you could see that there were quite a lot of interest from various disciplines, and pretty much covering all of the allied health disciplines. And I think that was a very good reflection of the interest in this area. In terms of the seniority of doctors level, so PG1 means postgraduate year, so 1 being an intern year and 2 and subsequently, you can see that majority of the clinical staff are in the first 2 to 3 years of their clinical practice. Okay. So just going to the knowledge-based test now, in summary, what we found was a couple of things. Firstly, there is an improvement of knowledge-based on knowledge, based on knowledge-based tests prior and comparing prior to post intervention. The baseline score is lower in the non-medical arm, which is partly what we expected, given they may not be be more well versed in the medical and the clinical aspects of patient care. And the magnitude of gain is also high in the non-medical aspect as well. That's also what we expected. But they were, in general, overall gain demonstrated in knowledge gain demonstrated in all the subgroups. And we also looked at whether the level of seniority of the medical staff actually affects them. We also managed to demonstrate that as well in terms of across all the subgroups essentially. With regards to the RIPLS, unfortunately the results are not that wasn't that what we expected. So effectively there was not much difference in terms of comparing pre and post intervention in terms of across the 3 domains. And I think part of the reason, I'll come to that in a moment, but I think part of the reason, apart from small sample size, is about having established roles and responsibilities in the workforce compared to the medical student cohort. Because this has been shown to have had positive effect in the undergraduate cohort, but unfortunately we weren't able to show that in our group. And then we also asked a question about the overall rating in terms of how important one rate interprofessional learning in fostering interprofessional practice. So it's a scale of 1 to 10, 10 being most important and 1 being not too important. You can see that most of the medical and non-medical staff do appreciate and value interprofessional learning, and most of them do find an improvement in terms of the overall rating score. The gain in the non-medical arm was not statistically significant, and I think partly it's because of just a small sample size that we have. And then towards the end, the review of the workshop. So we provided questionnaires to the participants and also giving them free text box, and we did a thematic analysis on them. And the common themes that comes out of all the participants in giving feedback for the workshop is that we find that simulation-based scenarios, the video itself, including involving multidisciplinary education and briefing, debrief post-simulation, and interprofessional learning is valued in promoting collaborative clinical practice. And in fact, the pre-simulation video was actually well received, and simulation was actually perceived as a useful education tool, with more than 90% of medical and non-medical staff strongly agree that they were an effective tool in providing education and training in the workforce. In terms of conclusion, limitation of the study includes that we have fairly limited small sample size, relatively. There were a lot of incomplete data in the RIPLS, and I think partly that's because it's a 19-question questionnaire, and it just takes people a long time to complete them, and the competing interests in terms of clinical commitments and just the time spending filling out the forms while they come to the workshop. Potential selection bias and recruitment bias, they were all volunteers, and the participants were not blinded because it was impossible to blind because they were in professional, interprofessional group. There were overrepresentation in females. There were improvements were better in females, but that's partly also because the nursing staff and the allied health cohort staff were pretty much female predominant in that aspect. And generalizability of this result to senior medical staff is limited, as most of the medical participants are of a junior years. In terms of the strength, we felt that it was a fairly efficient research method. Data collection was fairly straightforward, was minimal cost involved, and we were able to provide concurrent delivery of education and training at the same time as well. So effectively, what we've concluded was that the workshop improves the knowledge of participants in the clinical area of delirium care. The magnitude of gain is more so in the non-medical group compared to the medical group, partly explained by the pre-training level of knowledge. IPL was appreciated and considered an important aspect in fostering collaborative clinical practice. The non-statistical difference in the RIPLS may be due to small sample size, but the other explanation of it would be that when staff are in the workforce, they already have some idea or some established roles and responsibilities and some preconception of teamwork and collaboration leading up to that, and hence may have just blunted the effect of that. Feedback from participants suggests that simulation and IPL enhances learning experience, and I think a briefing video with a multidisciplinary-led briefing was a useful tool in providing consistent and reproducible training. So acknowledgement to the Australian Government and Australia Clinical Training Network for providing funding for our research, and also a brief acknowledgement to the Fiona Stanley Medical Education Unit, Nursing and Allied Health Education Unit as well for gathering the troops to have that many participants through in a short period of time. The Medical Illustration Department, Fiona Stanley, for providing all the guidebooks and videos and everything else in a very, very short period of time as well. Dr. Fan and Dr. Shute are both consultant psychiatrists that assisted in the delivery of the workshop, and numerous volunteer actors that were involved in the video production. Thank you.
Given that the feedback was that the IPL education and training was valuable, has it changed any of the current or future education and training that you will run? I'm just interested, given that there's the medical and the nursing and allied health units, are they working more cohesively beyond that, or do you anticipate that may occur?
I think the anticipation and the recommendation would be that we would like to foster more cross-discipline educational program. I think that what comes out from this is that people from different disciplines do have interest in having joint educational and training activities. So I think, in short, yes, but the practicality of it with workforce commitments and a few other things, I think it needs a bit of a push, and I think it might take a bit of time for that to be established.